Hello, welcome to the ISTH webinar series. I'm Dr. Georg Tamamian from Yerevan State Medical University and MD Anderson Cancer Center, and a member of the ISTH Young Professionals Task Force. I'll be moderating today's webinar. Today we'll be discussing antiphospholipid antibody syndrome, diagnosis and management, with Drs. Bas de Laat from Maastricht University and Maria Laura Bertolaccini from the King's College of London. Before we get started, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We'd like today's webinar to be interactive, and we encourage you to submit questions to our presenters using the Questions tab on the left side of your screen. Please feel free to submit your questions at any time. We'll be monitoring questions and we'll try to respond more quickly if we see something that shouldn't wait until the question and answer period. For example, if you need to clarify something. When asking your questions, please specify which speaker you would like to address the question. I'd like also to point out a neat feature for those that wish to take notes during the presentation. When you click on the Notes tab on the right-hand side of the screen, you will see a white box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the presentation. If you are interested in a PDF copy of the PowerPoint or would like to download any file referenced during this talk, you can click on the Resources tab on the left-hand side of the player. Simply click on any of the file names to initiate the download. Also, if you experience any technical problems during the course of this webinar, you can click on the Request Support button in the lower left of the player, and we have a technical expert there to help out with whatever problems you may have. So why don't we get started? First up is Dr. de Laat discussing detection.
Thank you very much for the introduction. I'm Bas de Laat, and I'm from the Maastricht University, and I'm also in the SSC Lupus Anticoagulant subcommittee from the ISTH SSC. I will talk about detection of thrombosis-related antiphospholipid antibodies. So let's start with a definition of the antiphospholipid syndrome. Because it's a syndrome, it's a combination of clinical symptoms together with laboratory detection of certain things that will make the antiphospholipid syndrome. The clinical symptoms can be either vascular thrombosis, which can be venous or arterial thrombosis, and specific pregnancy morbidity. And over here on the left you can see several of the clinical features which a patient suffering from the antiphospholipid syndrome can have. You can see it's quite heterogeneous and many things can happen also besides the antiphospholipid clinical symptoms like thrombosis and pregnancy morbidity. Then the laboratory detection. You can either have a defect or a change in clotting assays, such as a prolongation of phospholipid-dependent clotting assays. These are called lupus anticoagulants. An anticoagulant because it prolongs the clotting assay. Mostly APDT assay and a DRVVT assay are used to detect these prolongation of phospholipid-dependent coagulation assays. Second of all, patients can test positive in certain solid phase assays. These assays are used to detect antibodies against predominantly beta-2 glycoprotein 1. And the two assays that are approved to diagnose a patient with the antiphospholipid syndrome are anti-beta-2 glycoprotein 1 antibodies, either IgG and IgM, and anti-cardiolipin antibodies, also from the IgG and IgM class. So go on with the laboratory detection. So you can have the clotting assays and these antibodies, these antiphospholipid antibodies, can prolong these assays. So how do you use these clotting assays in practice? We advise not to use more than 2 coagulation tests for detecting this lupus anticoagulant phenomenon, because when you use more, you have the risk of overdiagnosis of the syndrome, and to use not a test that is insensitive for luck, And also to remember that no test is sensitive for all kinds of lupus anticoagulants, because a lupus anticoagulant can be caused by different subtypes of antibodies. And what we recommend is to use either the DRVVT or the APTT. We did that both on practical reasons and also on scientific reasons. Mostly on practical reasons, because the DRVVT is widely used and is most robust, and the APTT is highly sensitive for lupus anticoagulants when using silica as activator and has a low phospholipid content. Which we do not recommend is the dilute PT, because there's a variability in thromboplastin regions, the eccrine and texturin clotting assay, because at this moment there is no standardized commercial assay available, and the kaolin clotting time, because there is a poor reproducibility. So how to test, how to use these assays in practice? Well, I will not go into detail of these tests, because they can be read in several articles published by the ISTH SSC, and here you can see several facts that has to be taken into account. You have to have a good blood collection, so to start before medication or after discontinuation. You have to have fresh blood on sodium citrates. Double centrifugation is very important to remove all phospholipids. Then the choice of test, I already said it, there's an APTT or a DVVT, and lupus anticoagulant is positive, one of the two is positive. You can have a mixing test, and this mixing test is to exclude factor deficiencies. You have expression of results, which are also written down in several documents by the ISTH SSC, and you can have a confirmatory test, because the addition of extra phospholipids can reduce the lupus anticoagulants. And these phospholipids have to be biallase of the hexagonal second phase of the phospholipids, which means that the polar heads of the phospholipids are turned inside. So here you can see on the right what you can do, how to test with a screening test, then mix, confirmation, and repeat after 12 weeks, because sometimes certain conditions give positivity in this lupus anticoagulant test, but after 12 weeks there's no positive signal anymore, and this was caused not by antiphospholipid antibodies but by other diseases. So then the solid phase assays. Like I said, you can have the anti-beta-2 glycoprotein-1 ELISA or solid phase assay, and the anticardiolipin ELISA. And here you can see that mostly both of the assays, both the cardiolipin assay and the beta-2 assay, are based on binding to the protein, beta-2 glycoprotein-1. And this is the most important protein in the antiphospholipid syndrome. Here you can see on how a cardiolipin assay is made. Here you can see the cardiolipin. You can see the beta-2 glycoprotein-1 is coated on top, and there's an antibody binding. And with the beta-2 glycoprotein-1 assay, the beta-2 is bound to a negatively charged surface. I will come back to that later, why that is needed. And then the antibody binds to it. And we think that one antibody binds two proteins, two beta-2 glycoprotein-1 proteins, to be stabilized on the surface. And both assays detect IgG and IgM antibodies. So why does the lupus anticoagulant correlates better with thrombosis than the solid phase assays? Because that is known, but why is that? And I think that the standardization has not yet been achieved for the solid phase assays, and some issues remain unclear and unanswered. So how to calculate cutoff values for these assays? The choice of assays, which assay will you use in practice? And the technical performance and characteristics. These are described in guideline, but focus on ELISA and not on the modern platforms, the automated systems. And there's a lack in uniformity in calibration. And also the units of antibodies. What do these units mean? So in 2012, there was an official communication of the SSC with guidelines for detection of antiphospholipid antibodies by solid phase assays. And one of the things that we also published is the recommendations, and you can see the guidance from the SSC of the ISTH, how you should perform a solid phase assay. And it's it covers most of the things how to use this in practice. I will not go into details because this can be read, and here you can see the reference to it, but all kinds of aspects will be dealt with in this concise paper. So then the clinical correlation. Like I said, lupus anticoagulant is at this moment the best assay to be used to detect patients at risk for thrombosis when suffering from antiphospholipid syndrome. Here you can see from the largest risk factor to the smallest risk factor how it's now thought. There is no clear scientific evidence for this except some meta-analysis, but for lupus anticoagulant is certain. This is correlate best with thrombosis. Then you have the beta-2 glycoprotein IgG antibodies that correlate well with thrombosis. And then the correlations go down and gets worse and worse and worse. For pregnancy morbidity, people don't know. What we do know is that lupus anticoagulant correlates best with thrombosis, but for the other assays, it's just not known. Some say it's the IgG, others say it's the IgM. At this moment, I also don't know. So, in which patients do we test for antiphospholipid antibodies? Because many patients have arterial venous thrombosis, but not everybody has the antiphospholipid syndrome. And should we test for every patient that had a history of thrombosis to prevent rethrombosis when it's positive for antiphospholipid antibodies? Well, certainly not. One of the reasons is a very practical reason is because of the cutoff for the tests. Because when you have 100,000 patients with thrombosis, and you do all phospholipid tests like the APTT, the DRVVT, both the IgG and the M4, beta-2 and anticardiolipin, it means that many patients will test false positive because all assays are based on 99% cutoff, meaning that at least 1% will test false positive for the assays. So you have to be really careful who you will test for these assays. And that's why in the guidelines it's included the appropriateness to test, for example, lupus anticoagulant. It's low in venous and arterial thrombosis in elderly. There's a moderate importance when accidentally found prolonged APTT in asymptomatic recurrent spontaneous pregnancy loss or provoked VTE in young people, and it's high in unprovoked VTE and or unexplained arterial thrombosis in young patients, and several other conditions are involved in this high importance to test for antiphospholipid antibodies. So then those three assays, do they detect all the same antibodies? No. You would expect, because an antiphospholipid antibody should be an antiphospholipid antibody and should be positive in these assays. But it's not the case. There are different populations of antiphospholipid antibodies. Like you can see over here, a cloud of patients positive for lupus anticoagulant. Here you can see a cloud of patients positive for anti-beta-2 glycoprotein 1 antibodies. And over here, the anticardiolipin antibodies. So you can see in the middle, a big bunch of patients are positive for all three, but there are also patients for only one. So when you test more positive for all three tests, do you have a higher chance of rethrombosis, and do you have a more definite antiphospholipid syndrome? So Professor Pengo did a lot of studies on this aspect, and he introduced the term triple positive, and he nicely showed that, for example, over here, he tested several patients and looked whether their tests are still positive after 12 weeks. And you can see that when patients are triple positive, so they are positive for lupus, beta-2 and anticardiolipin, they remain positive, almost all, I think this was 98%, remain positive after 12 weeks. When you have double positivity, then it's already less. Over here, I think it was 81 or 82%, and a single positivity, only 40% after 3 months was positive. So also patients, when they have the triple positivity, are more likely to have definite antiphospholipid syndrome. Then the risk for thrombosis in the antiphospholipid antibody carriers. And you can see carriers of triple positivity, and they looked how many events they would have, and the annual rates of first cardiovascular events. And this is a nice study that shows that when you are triple positive and you are carrier of this triple positivity, you have a much higher chance of getting thrombosis than when you are single positive. And here you can see you control the normal subjects. So again, over here, when you are positive for all three factors, then you are more likely to, in the future, to get an event of venous or arterial thrombosis. So, do we really need this triple positivity, and is there an alternative? So, there are problems with solid phase assays. Like I said, the log correlates well with clinical symptoms, and this might be the case because it's a functional assay. Although it detects the prolongation of the clotting, it's still a functional assay detecting functional activity of antiphospholipid antibodies. The solid phase assays are more difficult to standardize, as several factors influence the test outcome, like blocking solution, charge of the plate, the conformation of beta-2-glycoprotein 1, and the source of beta-2-glycoprotein 1. For example, with the blocking solutions, we did a study already in 2004 where we looked in a homemade beta-2-glycoprotein 1 ELISA whether a difference in blocking solutions influences the results. Here you can see the different blocking solutions that we used. Over here you can see the blanks, and over here you can see the signal of an anti-beta-2-glycoprotein 1 antibody. You can already see that there are differences, for example, in the signal, it goes down, and over here also in the blanks. This is a quite high blank. The funny thing is that these two should be the same, but there are different batches of the same company. So even in batches of blocking agents, there are differences. So this already shows that a blocking solution is very important for your antiphospholipid assay, for your beta-2-glycoprotein 1 ELISA. Then the charge of the plate is this important. Over here we did a little bit of a complicated test, the upper panel, where we looked at whether we could catch beta-2-glycoprotein 1 from solution. Over here we coded an antibody against beta-2-glycoprotein 1, then added beta-2 plus these two antibodies to it and a blank, and looked whether a second antibody could still bind beta-2. But what we looked at is whether these antibodies could bind beta-2-glycoprotein 1 in its native conformation. And this is a special antibody because this antibody was not able to catch beta-2-glycoprotein 1 from solution. Although this antibody has a high affinity for beta-2-glycoprotein 1, which can be shown over here in a normal beta-2-glycoprotein 1 ELISA. This already shows that also the conformation of beta-2-glycoprotein 1 is quite important in catching the antibodies from the solution. So then to the most important thing, which I think is the most important issue with the current solid phase assays, is the conformation of beta-2-glycoprotein 1. So beta-2-glycoprotein 1 exists in different conformations. Here you can see how we think is the native conformation, which can be either circular in solution or an S shape. And when it interacts with phospholipids, it becomes straight. And what then happens, which you can see in this panel over here, is that the epitope on domain 1 becomes available for antibodies to bind. So there is a conformational change in beta-2-glycoprotein 1 when it binds to phospholipids or to negatively charged surfaces. So these antibodies that we should detect, we know that are heterogeneous. They bind different epitopes on beta-2-glycoprotein 1 because it's published that almost every domain of beta-2-glycoprotein 1 is able to bind some sort of antiphospholipid antibody. We thought maybe we can design an assay that we can discriminate between pathogenic and non-pathogenic epitopes. And this is already published on domain 1. So there's an epitope on domain 1 which becomes available when beta-2-glycoprotein 1 erects and shows its hidden epitope. And this hidden epitope on domain 1 has been described now in many papers to bind phospholipid antibodies. You can see some, And here you can see how we think that it goes. You have either the circular form of beta-2-glycoprotein or the S form, then it binds to phospholipids, it goes up, and over here is the epitope, which then can bind the antibodies. And what was published by the group of Giannakopoulos and Professor Krilis is that also oxidative stress can unmask the critical domain 1 epitope of beta-2-glycoprotein 1. So there's a lot of indirect evidence that shows that antibodies against domain 1 have a higher association with thrombosis. We also published several studies on this aspect, showing that when antibodies bind to the first domain of beta-2-glycoprotein 1, they highly correlate with thrombosis, and others do not. Here you can see some more papers. And there's also direct pathogenic evidence in mice models where they showed that when antibodies against domain 1 were induced, then these mice had a higher chance of thrombosis, or their thrombi were bigger. And also one of the studies that we did in mice where we injected beta-2-glycoprotein 1 and also detected domain 1 antibodies in these mice, and fragment 1 and 2 was higher. So how does triple positivity, published by Professor Pengel, correlates with these domain 1 antibodies? Well, here you can see the domain 1 IgG, and here you can see the triple positivity, the double positivity, the single and the controls, and you can see when a patient is positive for more assays, they have a higher chance of high levels of domain 1 antibodies. So this correlates well with triple positivity. So then the variability in these anti-beta-2-glycoprotein 1 ELISAs, which I've been hammering on, and we think that the conformation of beta-2-glycoprotein 1 might affect the detection of beta-2-glycoprotein 1 antibodies and adds up to the interassay variability. So we wanted to compare the exposure of epitope G40R43, which is this cryptic epitope on domain 1, and to see whether exposure of this epitope is a reason for the high variability. Here you can see one of the studies that we published. We first isolated 2 antibodies against domain 1 from patients via phage display. One antibody, this antibody that only binds domain 1 when it's available, and this antibody binds domain 1, doesn't matter which conformation beta-2 is in. And here you can see when we bind plasma beta-2-glycoprotein 1 on a hydrophilic plate, both antibodies will bind. But when we bind beta-2-glycoprotein 1 on a neutral plate, so beta-2 won't open up, this antibody, P117, will not bind to the coded beta-2-glycoprotein 1. And here you can see a mutant where this epitope was mutated out, then still this antibody will not bind to this domain. So we have 2 antibodies. Here you can see the summary of the study. One will bind domain 1 on this aspect of the protein, and over here you have an antibody that only binds to beta-2 when it's in an open conformation. So what we did was we compared 5 assays and looked whether these 2 antibodies showed different results in these assays. So over here you can see assay A, that both the antibodies bind almost to the same extent to the coded beta-2-glycoprotein 1, which means that the beta-2-glycoprotein 1 almost always in its open conformation and able to bind these antibodies. But you can also see that assay B has a lower affinity for P117, which means that a certain population of this beta-2, the domain 1 is not exposed. So this might be one of the reasons why a patient can test positive in SAA and not in SAB, or vice versa. So this might explain the variation between the assays that are now on the market. So here you can see another study that we did is to see whether the regions on the plate would affect the antibodies. I will not go into detail, but indeed the regions on the plate did. And here you can see another study that we did in a cohort of patients where we selected 20 patients, 10 that were domain 1 positive and 10 that were domain 1 negative. we looked at assay A, the one in which all the beta-2 was open, and in assay B, where a certain population of the beta-2 was still in its closed conformation and unable to bind to domain 1 antibodies. You can see you have differences in patients. For example, you can see over here patient 2, 3, and 4, and even 5 are low positive or medium positive in assay A, but they are negative in assay B. So you will miss these patients in assay B. And you can see for the really strong antibodies, you will have a nice comparison, but for the other ones, there are not good results and a high friability. So also did it in a different cohort, which was a little bit larger, with 149 domain 1 negative patients and 23 domain 1 positive patients, and there you can see that again, assay A detects 22 out of 23 domain 1 positive samples, but in assay B we miss some patients. And again, also in this cohort, we show that there's a variability means that you have a variability in detecting these patients. Together with Professor De Vreese, we also did a study in automated assay like AccuStar and Bioplex. And you can see that in the IgG assay, in the AccuStar, that some of the beta-2 is not opening up, and you have differences between these antibodies in this assay. And you can see it also with the beta-2 and with the anticardiolipin. And you can see with the Bioplex, the beta-2 is almost all in its open conformation. So there are also differences between automated assays, and these differences may result in differences in sensitivity between the two assays for future beta-2 glycoprotein 1 testing. So I think the recommendation should be that domain 1 assays correlate better with thrombosis than the classic anti-beta-2 glycoprotein 1 assays. And there are different assays available for these detecting these domain 1 antibodies. So there's a two-step approach which we developed, which can be read in the paper and be copied. There's also a domain 1 assay by Innova Diagnostics, which is research only. There was a paper by the group of Vittorio Pengo, and there's now a novel beta-2 domain 1 chemiluminescence immunoassay also developed by Innova. But at this moment, there's insufficient evidence to claim that only domain 1 is important to be detected, because we don't know whether there are other populations that highly correlate with thrombosis, for example, against domain 4 or domain 5. So that is one of the things that need to be investigated in the future. So the conclusion is that at this moment, the LAC assays correlate best with clinical symptoms. There has been improvements in the standardization of the guidelines to perform solid phase assays. There is standards to control the conformation of beta-2 glycoprotein 1 should be included in the assays that are now on the market. And assays that detect domain 1 might help diminishing the variability between different assays. At this moment, you can also do a triple positivity, and because triple positive patients are at the highest risk to get rethrombosis, and carriers of triple positivity have the highest risk for getting thrombosis. So these are the acknowledgements I would like to do, and especially Hilde Kelchtemans, who helped me with several of these slides. Thank you for your attention.
Thank you, Dr. De Laat. As a reminder, we'll address all questions after both talks have concluded. We'll now continue with Dr. Bertolaccini, who will discuss state-of-the-art treatment.
Hello, thank you very much. So my name is Laura Bertolaccini. I am a co-chair with Bas De Laat for the subcommittee in lupus anticoagulant and antiphospholipid antibodies. And in the next few minutes, I'm going to present some data relevant to state-of-the-art treatment in APS. So as you all know, the antiphospholipid syndrome is characterized by vascular thrombosis and or pregnancy morbidity, and it occurs in patients with persistent antiphospholipid antibodies. So the antiphospholipid syndrome shows a wide range of clinical manifestations. You may find patients who are only positive for the antibodies. The patients more commonly seen are those presenting with venous, arterial, or small vessel thrombosis. Pregnancy morbidity is one of the hallmarks of the antiphospholipid syndrome in women, and is presented by miscarriage or fetal loss, preeclampsia, and growth restriction. There are other wide range of non-criteria manifestations for the antiphospholipid syndrome, like livedo reticularis, thrombocytopenia, hemolytic anemia, cardiac valve disease, and the most dangerous of the situations, that is the so-called catastrophic APS, where the patient presents with multiple organ thrombosis, commonly associated with multi-organ microangiopathy. So what is the treatment consensus? It is widely accepted that long-term anticoagulation should be the treatment of choice for thrombotic events, and aspirin with or without heparin, a low molecular weight or unfractioned heparin, should be the treatment of choice for pregnancy morbidity. So what is the thrombotic APS treatment at the moment? Well, we know that it's long-term anticoagulation. For venous events, it is accepted that anticoagulation should be reaching a target INR between 2 and 3, and for arterial events, the target INR should be between 3 and 4. Some centers or some experts claim that target 2 to 3 plus the addition of antiplatelet agents could be an option, although this is quite a dangerous combination because of the risk of bleeding. And some others claim that antiplatelets alone should be only used in patients after the first arterial event. So what do we know about vitamin K antagonists? The treatment in general is problematic. There are numerous drug and food interactions reported. It requires frequent monitoring. There is the big potential of under or over anticoagulation due to these numerous interactions, and monitoring of anticoagulation may be complicated by variable responsiveness of thromboplastin reagents on the laboratory where the monitoring is done. For obstetric complications, the recommended treatment is overall, if the woman presents only with miscarriages, no previous thrombosis, the treatment of choice is aspirin monotherapy. In the presence of fetal loss and always in the absence of previous thrombosis, they usually choose between heparin and fraction or low molecular weight heparin with or without aspirin. If the patient has obstetric APS plus previous thrombosis, again, heparin and fraction or low molecular weight with or without aspirin is the treatment of choice. Warfarin can be used, but only in resistant cases and after the 14th week of pregnancy, and this is due mainly to the teratogenic effects of warfarin during early embryogenesis. So what is the most important in the obstetric APS is that oral anticoagulants should be discontinued before pregnancy or at conception, and there is the need of close monitoring of fetal and maternal health. So far this is the treatment that is being used by most of the centers, but what I wanted to do today was to give you an overview of potential new treatment strategies that are being investigated in the antiphospholipid syndrome. So the first, of course, are the new oral anticoagulants. We have two types, the direct thrombin inhibitors, such as dabigatran, and the factor Xa inhibitors, such as rivaroxaban, apixaban, and edoxaban. These are easier to use because you only need a fixed dose. They have a predictable anticoagulant effect. They do not interact with dietary constituents or alcohol. There are very few reported drug interactions, and the monitoring of anticoagulant intensity is not routinely required. So we know that their efficacy for venous thromboembolism has been widely demonstrated in large phase 2-3 clinical trials, but there is only one completed study in patients with APS. This is the RAPS trial, rivaroxaban in antiphospholipid syndrome. Results from this trial were recently presented at the ISTH meeting. This is a phase 2-3 non-inferiority randomized clinical trial. The principal investigator is Dr. Hannah Cohen from University College London, and the participating centers are University College and St. Thomas's Hospital. The hypothesis for this trial was that the intensity of anticoagulation achieved with rivaroxaban was not inferior to that of warfarin in patients with thrombotic APS. This trial included 116 patients. The anticoagulant effect of both drugs were measured by the thrombin generation test. So in this trial, there was not a clinical outcome, but a laboratory outcome, the effect of these drugs on thrombin generation test. So what are the results of the trial? Although rivaroxaban was inferior to warfarin in reducing the endogenous thrombin potential, other thrombin generation parameters show significant benefit for rivaroxaban when compared to warfarin. In vivo coagulation activation markers and clinical outcomes show no difference in risk between rivaroxaban and warfarin, and which is more important, the clinical follow-up show no thrombosis and no bleeding at 6 months' time. So what are the recommendations from the experts in the use of new oral anticoagulants? Well, most of the experts agree that vitamin K antagonists remain the mainstream treatment in APS. There is not enough data to recommend routine new oral anticoagulants used in APS, although these are being widely used in patients who present to accident and emergency with thrombosis. So NOACs may be considered when there is a known vitamin K antagonist allergy, when there is intolerance, and when there is a poor anticoagulant control. I think it's very important here to make the point that as patient adherence is clinical, as there is no monitoring for the drug, non-adherence to vitamin K antagonist should not be a reason to switch an APS patient to new oral anticoagulants. Other drugs available for the treatment of thrombosis are indirect antifactor Xa inhibitors. The data that is available on the antiphospholipid syndrome is mainly limited to the use of fondaparinux. There are anecdotal case reports and a small case series of successful use of this drug in APS patients with heparin-induced thrombocytopenia, and therefore the recommendation is in these sorts of cases. One drug that is being widely used in autoimmune systemic diseases and in the antiphospholipid syndrome is hydroxychloroquine. We know that in mice, hydroxychloroquine is able to reduce the extent and the time of thrombus persistence in APL-injected mice. It reverses the thrombogenic properties of APL and reverses the antiphospholipid antibody-mediated platelet activation. In humans, there are some early placebo-controlled studies from the late 70s, early 80s, where they show that hydroxychloroquine prevented postoperative thrombosis after hip replacement. But what is more important is, as this drug is being used mainly in lupus, it has been shown that hydroxychloroquine reduces the flares, the damage, the cardiovascular events, and the mortality in this population. So most of the studies available on hydroxychloroquine are in patients with lupus, where it has been reported that the use of hydroxychloroquine is protective against the development of thrombosis. What about the use of hydroxychloroquine in secondary prevention? There is only one trial available, a prospective non-randomized trial, including only 40 patients with thrombotic APS with primary antiphospholipid syndrome. And the investigators compare the use of oral anticoagulation plus hydroxychloroquine versus oral anticoagulation alone. Their trial reports that 30% of venous events were seen in the monotherapy group versus 0% in the anticoagulation plus hydroxychloroquine group during 3 and 36 months follow-up. So what are the recommendations? There is no strong data to recommend hydroxychloroquine in persistently APL-positive patients without other autoimmune diseases. However, as hydroxychloroquine may reduce the risk of thrombosis in experimental models and SLE patients, it may be considered as adjunctive treatment in refractory cases. So far, there is no data available in antiphospholipid syndrome alone, and I think more trials are needed. Another drug that is being used are statins. They are pleiotropic, immunomodulatory, anti-inflammatory, and antithrombotic drugs. In vitro studies have shown that fluvastatin, simvastatin, and rosuvastatin reduce APL-mediated tissue factor expression, which is the first initiator of thrombotic events. And in mouse models of APS, simvastatin and pravastatin have been shown to reduce the fetal death rate. Studies in APS patients come mainly from Andalusia, from Córdoba, from the group of López Pedrera, where they show that fluvastatin downregulated tissue factor and other prothrombotic markers in the antiphospholipid syndrome. A study from Doru Kerkan in New York from HSS showed that fluvastatin significantly and reversibly reduced pro-inflammatory and prothrombotic markers. And there is a case reported in hypertension in 2014 by Dr. Elmina Lefko, and a case series recently reported at the ISTH, where pravastatin reversed preeclampsia in antiphospholipid syndrome. So what about B-cell inhibition? So there are several case reports on the use of rituximab in severe thrombocytopenia, hemolytic anemia, skin ulcers, and APL nephropathy. There is not a consistency on the response found with the use of this treatment. It might have a role in the management of refractory catastrophic APS, and this data comes from the international web-based CAPS registry, where from 20 patients who received rituximab, 15 recovered and 5 died. There is data from one trial recently published in Arthritis and Rheumatology, the RETAPS trial. This was a pilot open-label phase 2 study to evaluate the safety of rituximab in primary antiphospholipid syndrome. Patients were given 2 doses of intravenous rituximab. The study included only 19 patients and concluded that rituximab was safe to use in APS, although it did not induce substantial change in APL profiles. It was effective in controlling some non-criteria manifestations, including thrombocytopenia, skin ulcers, and cognitive dysfunction, while it showed no effect on cardiac manifestations. Complement inhibition is another potential treatment. We know that complement is implicated in APS via the generation of the mediator C5a that contributes to vascular inflammation. And in a mouse model of APS, the interaction of C5a with its receptor was necessary for APL-induced placental insufficiency, inflammation, and thrombosis. What about drugs for complement inhibition? Well, all data available in the literature is on the use on eculizumab. Data is restricted to few case reports, mainly post-kidney transplant, thrombotic microangiopathy, and catastrophic APS. There is one ongoing trial to investigate the use of eculizumab to enable renal transplantation in patients with previous history of catastrophic APS. Unfortunately, I couldn't find recruitment and no results are available. There is no enough data to recommend the use of eculizumab, And significantly, it's important to mention that the price may be quite prohibitive. Other treatments that may be available is peptide therapy. There are some studies and some centers trying to develop peptides targeting the APL domain 1 interaction by deletion or mutation of the domain 1, and the TIFI or the GDKV peptide is an homologous peptide to cytomegalovirus TIFI. It inhibits thrombosis in mouse femoral vein pinch model. However, there are no peptide therapies currently available, and none of these peptides are being trialed for the antiphospholipid syndrome at the moment. So in conclusion, the current mainstream treatment for APS is still long-term anticoagulation. We all know that the management is currently suboptimal as anticoagulation is not fully effective. New drug development is challenging because we have a limited understanding of the origin, specificities, and biologic activities of APL, but we do believe that current antithrombotic approach may be replaced by a safer immunomodulatory approach as we understand more how these antiphospholipid antibodies act. And more studies and clinical trials are needed. And for whoever wants to go further into the data presented today, I recommend these two reviews, one published on Autoimmunity Reviews that are the recommendation of the Antiphospholipid Antibody Task Force on Treatment Trends, and a recent review from Ricard Cervera in Nature Reviews in Rheumatology. Thank you very much.
Thank you, Dr. Bertolaccini. Both lectures were very interesting. Thanks a lot to both speakers. So we'll now begin the question and answer session. And we got several questions here. The first question I'm going to ask is directed to Dr. Delat. So could you comment on lupus anticoagulant testing in the setting of direct oral anticoagulants?
Yes, I could certainly do that. It's a very difficult question because should you treat already patients with these direct oral anticoagulants or not, especially the rivaroxaban and dabigatran. There are now several studies on the way, and testing, I think, in the future is needed. But will it affect the lupus anticoagulant testing? Yes, it will affect lupus anticoagulant testing. We did one study, I think now 2 years ago, which was published in JTH. We showed that both the DRVVT and the APTT was a little bit, were both affected by rivaroxaban. The APTT less than the DRVVT, but both were still affected by rivaroxaban. And what we did was we did a trick, and we were able to detect the lupus anticoagulants using the Eccrine versus the type in snake venom sort of assay like that. But that was a homemade assay. For the dabigatran, we didn't have a solution yet because dabigatran will also affect your lupus anticoagulant testing. What I would suggest is either when it's possible to have a clean sample without the anticoagulants. Mostly that's not that cannot be done, and then I would do the solid phase assays. And when you get your hands on the domain 1 assay, for example by Innova, I would use that test.
There are quite many questions, so let's just briefly go into each of them. And the second one, I guess, is to Dr. Bertolaccini. Should we discontinue vitamin K antagonists during menses in women experiencing menorrhagia and having antiphospholipid antibodies?
Well, I am not a clinician myself, but I can tell you what they do at St. Thomas's. They do not discontinue warfarin, but usually what they do is to use a Mirena coil.
Okay, thank you. So we have quite many questions on clinical issues. I mean, I can just read, let's go through of the ideal contraception while on VK and having antiphospholipid antibodies. Can you comment on here?
It should be without estrogens. So they should use a contraception, no estrogen contraception.
What about, thank you, what about administering VKAs to patients with lupus nephritis but no venous thromboembolism?
I suppose that question implies that there is thrombotic microangiopathy in the biopsy.
Yeah.
Is that correct?
Yeah, VTE, but not VTE.
Well, thrombotic microangiopathy is one of the clinical manifestations of the antiphospholipid syndrome. So if you have a patient with thrombotic microangiopathy and antiphospholipid antibodies, anticoagulation could be recommended.
Okay, so what's your experience with point-of-care monitoring INR tests in patients with antiphospholipid syndrome?
All our patients are monitored at the coagulation clinic at St. Thomas's Hospital. We don't have a lot of experience on home testing or finger stick testing. So all our patients are monitored in the coagulation clinic.
Okay, thank you. And another question is, should chromogenic factor 10A assays be done on a regular basis, like 3 or 4 months, to assess the accuracy of INRs in patients on warfarin therapy with antiphospholipid syndrome?
We don't do factor 10A assays. Why should we do factor 10A assays or chromogenic assays? We don't do that. So to control the target or the good anticoagulation, what we do is an international normalized ratio, prothrombin time international normalized ratio.
Great, thank you. And another question to Dr. Bertolaccini. There is a patient with APS and recurring VTE during adequate anticoagulation. Would you consider adding acetyl salicylic acid or hydroxychloroquine to VKA treatment, or would you choose B-cell inhibition?
Well, most of the experts in the field would suggest adding aspirin if there is recurrency. Another option is increasing the INR, target INR.
Okay, thank you. And the last question comes about, so BCSH and CLSI guidelines do not limit the screening and identification of lupus antibody using silica-based reagent only. More than this, reagent sensitivity to LA is more dependent on the phospholipid type concentration. Why SSC say differently?
Yeah, that's a very good question.
Yeah.
And we have had many discussions with people from the CLSI and discussions within the SSC, and we are more strict on this aspect to diminish the amount of assays on the market to reduce also the variability between the assays. But the statement is correct. There are other assays on the market that can detect lupus anticoagulants, and not only using silica, for example, but we would like to not to have many assays with the chance again of variability, but to reduce the amount of assays and be certain that one lab is testing the same antibodies as the other lab. But this is an ongoing discussion.
Thank you, Dr. Delat. We got another one question. Let me just take it. So there's a question that, I'll just read it. My mentor stated that INR may not be accurate in patients with antiphospholipid syndrome, and the factor 10A assay may help to determine if INR is accurate. Are INRs accurate in all patients with APS? yeah, Dr. Bertolaccini, I think you need to comment.
Well, I think we can both comment on this. But So I think there was this theory that lupus anticoagulant could interfere with the INR, and the INR was not reliable in patients with the lupus anticoagulant. The data is very controversial, but I think that most of the people accept that INR are reliable even in the presence of the lupus anticoagulant. So factor 10A, I don't think it would be a necessary test to do unless the patients are on heparin.
No, I agree. There is not much data confirming that lupus anticoagulant can interfere with an INR, although we have seen it, but it's really rare. And to do in all patients a factor 10A assay is quite costly, and to my opinion, it's not needed.
I have one question just from me about the thrombocytopenia in APL, antiphospholipid syndrome. So do you see it frequently? I mean, and how severe is it usually?
Well, thrombocytopenia used to be one of the criteria for antiphospholipid syndrome, one of the first criteria that we use for antiphospholipid syndrome. It is quite frequent. It's seen around less than 100,000 platelets, and it's usually respond well to treatment. So it is quite frequent to see patients with antiphospholipid and thrombocytopenia. What is important is that the risk of bleeding, despite the thrombocytopenia, is generally not that high, although you need to control the patients closely.
So it's, I mean, it's quite mild, yeah? The thrombocytopenia.
It is usually around 100,000 platelets, yeah.
Okay, yeah. Okay. So thank you very much for the both lectures and for the very nice questions and answers. And I wanted to thanks also to our sponsor of today's presentation, Instrumentation Laboratory. We hope you found this educational and enjoyable. When the webinar ends, we'll be able to complete a quiz and evaluation either for CME or a certificate of completion. A follow-up email will be sent to all attendees when the recording is available. The email will also include a link to the evaluation and quiz for attendees who cannot complete their CME immediately following the webinar. Our next webinar on platelet proteomics and current techniques in measurement of platelet protein phosphorylation will feature Drs. René Zahedi and Khalid Nassim. Please see the website for details and to register. As a reminder, all of the webinar series are available in archive at the website for your reference. Thank you again for joining, and we'll see you next time. Have a nice day.